Hi all, this is Katie, and believe it or not, we are halfway through this course. So I just wanted to give a brief, debrief from our first deep dive into week 3 and give you an overview of the upcoming week. Great job, everybody. I was really impressed with your posts and your submissions. I kind of wanted to just dip our toes, randomized controlled trials, most of us are familiar with, but you all did a really good job on your citations as well. I just wanted to remind you up here to the right on our DMS library page as we move along, we want to keep in mind proper AMA references. This is going to be really important going into your capstone. But there's a great resource on our page if you ever need to look that up. So I wanted to point that out. As far as our discussion, I really thought it was excellent work. Most of you commented in one way or another about disparities and healthcare compliance. And this is something I think earlier in my career I was just trying to get through my day and make sure I was treating patients properly, but really thinking about reasons for exacerbations is many times due to non-compliance. And this is really stressed over and over in various clinical practice guidelines in these really common disease states, okay? So, we do have disparities in healthcare. We need to keep this in mind. Many of you mentioned reasons for non-compliance, especially cost. Cost is a huge barrier, and some of you mentioned having case management and other resources, but there's other barriers, as well to keep in mind, and you have to ask the direct questions because most people aren't going to offer that for you. There are things like, are they using expired medications? Look at their medications because maybe they borrowed it from a friend. They can't afford it, okay? So that's a cost barrier. But what about transportation? At the extremes of age, or, if somebody doesn't have a car, the ability to get to a pharmacy, or they are moving around, or they're homeless, or living with friends, they may not be able to have that ability to get mail-in or the, education status to know how to do it. They may not be literate, okay? I always think about continuity of care. There was a great point about perhaps your questionnaire and the severity of their disease is not quite clear because the patient has adapted to their current disease state, right? And this could be important moving on to COPD in our next week. So Gina has some updates. I think that should be a mainstay of your practice guidance. Really stressing having a written action plan. There is some issues with environmental factors, and children in particular can't usually change those, right? So let's move on. There are some other changes in GINA. They have a summary slide available on their website, which is really helpful, and I just tried to make a couple quick points here. Making a written asthma action plan is really important because, or even if it's digital, have them take a picture of it because this is going to be really important for compliance. And GINA wants to stress that don't just give verbal instructions, okay? People aren't going to remember. Acute asthma in healthcare settings, at present, albuterol is still the oldie and goodie. There was a major change in 2019 with the fundamental change. The last 50 years, we were treating asthma with short-acting bronchodilators, but this is no longer recommended for adults and adolescents, okay? Any patient who is admitted to the hospital, they're going to either continue or commence inhaled corticosteroids containing therapy, okay? They do know that air filters, which we recommend all the time, they can reduce faint particles, but there are no consistent effects on asthma outcomes. and the use of e-cigarettes is associated with increased risk of respiratory symptoms and asthma exacerbations. I just wanted to point that out because that's a common question. Again, they're stressing that the overuse of short-acting bronchodilators are associated with increased exacerbations and increased mortality rate. And in terms of steroids, which this week's discussion, our patient did need to go home with a short burst. There is evidence that even 4 to 5 lifetime oral corticosteroid courses, they can increase the risk of badness, okay? Osteoporosis, diabetes, cataracts. We really want to maintain our control of exacerbations to avoid oral corticosteroids, and the correct taper for that is prednisolone, 5 to 7 days for adults, standard dose. You don't need to taper this, and 3 to 5 days for children. So coming up this week, at a glance, we're going to have the same structure. I've got a screenshot over here to the right. Basically, go ahead and review the lecture. I included a really good podcast from one of my favorite resources there, Curbsiders. They've changed my practice at times. I just listen to them while I'm in traffic, and it's a great way to build CME as well. Go ahead and read the recommended readings. There's a website review attached to a discussion, and this is not graded this week. I did not include it in the original rubric, but you all had such a great interaction last week. I thought I would put that out there. This is a heavy topic, so I didn't want to overburden you, but it is there, and I'll probably be participating in it this week. Go ahead and complete the EBM assignment. This is going to be case-based, utilizing practice guidelines. And of course, you have your quizzes. Okay? Just a word about our evidence-based medicine this week. We're going to be looking at a clinical practice guideline. You were introduced to the GINA guidelines last week with some other reading with asthma, but we're going to focus on actually putting this into practice. So how do we utilize this? I think it's 177 pages or 300, I don't know, hundreds and hundreds of pages of these guidelines. They usually have a pocket guide for you, usually have a tutorial that makes it a little less overbearing. When you first glance at it, you just are overwhelmed. I always am. But actually, as you go through the structure, it's very practice friendly, okay? So when we utilize clinical practice guidelines, there's a few things to keep in mind. This is going to be very high in your evidence pyramid. You are generally going to see a weighting example, which I'll show you the next slide. There's always a statement on how they made their guidelines and who comprised in the panel. So sometimes, again, these are guidelines. These are to help guide us. This isn't a substitution for individualized care, and I always stress this. So the difference in the structure of the guideline panel can influence the perspectives, okay? So panels may be comprised of specialists, primary care clinicians, or both. They often include other healthcare experts like epidemiologists, public health specialists, or statisticians. So the composition really may influence the perspectives and through which the evidence is interpreted or weighted, okay? So keep that in mind. Also, there are differences in the weight assigned to the evidence. So scientific evidence helps to describe the continuum of benefit versus harm. But guidelines are essentially, they're a value judgment on where to set your thresholds for recommendations. Okay, they're not a substitution for individualized care and decisions. Also keep in mind the panel's biases. Okay, so areas of uncertainty may be interpreted differently by different organizations. For example, clinicians see patients in the numerator, so they're oncologists. They're seeing cancer patients, so their clinical practice is constantly diagnosing cancer patients, right? Where in family practice we hopefully have very few of those. But their exposure is so predominantly to the benefits of treatment and screening, they may be more biased towards more aggressive guidelines. So if you are seeing these broader range of patients in the denominator, okay, like a primary care physician, like I said, or PA, excuse me, you're going to see the smaller ratio of diagnosed cancer, okay, compared with overall screening, and then maybe you see that potential harms are associated with screening without the benefit, okay, and then epidemiologists who may view rates and ratios may be biased more towards conservative guidelines and monetary savings. Here's a weight example. So when you see a guideline, they're always going to give you the kind of a category, how they weigh it, where their sources of evidence are included in that weight and the definition. So there's your quick introduction. As always, you can refer to our resources in our library. A couple of housekeeping items. I hope you all had a good first week. I just wanted to remind you that a timely post to the discussion boards will help you receive more interaction with your peers and feedback. You'll just get a little bit more involved in the class. As far as grading feedback, your grades are in for this week. I do post my comments within the rubric, and over to the right I just took a quick screenshot. If you see a purple box there, do press on that and that will open up the box that will show you my feedback in case you weren't aware of that. If there's no feedback, there'll just be a little plus sign it's down there in mechanics. So that one is empty. Okay, just wanted to point that out. I hope y'all have a great week.